Hello, everyone. Good afternoon or good evening, depending on where you're signing in from. Welcome to this week's installment of APP's in Urology Symposium. It is my pleasure to welcome Sofia Higareda from MD Anderson to give us an informative lecture on bladder cancer today. Before we begin, just some housekeeping items. If you would like to ask any questions, you can go ahead and use the Q&A button at the bottom of your screen, of your Zoom screen. We'll be saving the questions till the end, but you can start or write them down or send them in just so you don't forget any of them, and I will hold on to them and feed them to Sophia at the end when we have our Q&A section. If you have liked our webinars, if you want to continue to see more of them, we have 2 more that we're going to be having in this initial offering, and then hopefully can keep this program going. For more information about that, you can follow me on Twitter at EuroPA_SD, or you can follow UCSD Urology at UCSD_urology. This webinar and all past and all future webinars are going to be recorded or have been recorded and are available on our YouTube channel. So you can go ahead to YouTube and look up APP Symposium, follow us, become a subscriber so that you can get future pushes to let you know when videos are uploaded, and to see this lecture, which will be uploaded sometime later this evening for you to watch later on. And if you really like us and you want to see us keep going with this program, please tell all your friends and all your colleagues, send it to everybody, let them know that this is a great program. We are going to be looking into potential CME offering in the future as well. And so without further ado, I will introduce Sofia. So Sofia Higareda is a board-certified physician assistant, currently works at the University of Texas MD Anderson Cancer Center in Houston, Texas. She has over 8 years of experience in the field of oncology and has a growing passion for urology-related cancers, specifically bladder cancer. Sofia was born and raised in Houston, Texas. She earned a BA in microbiology from the University of Texas at Austin and a second bachelor's degree in clinical laboratory sciences from the University of Texas at MD Anderson. She worked at the MD Anderson Microbiology Lab for 5 years prior to obtaining a master's degree in physician assistant studies from the University of Texas Medical Branch in Galveston. Following graduation, she was offered a position at MD Anderson Cancer Center in GU Medical Oncology. She now works in surgical urology and has expanded her knowledge in prostate, kidney, and bladder cancer. Sofia is a strong advocate for practicing self-care and empowering others to be their best selves. She enjoys CrossFit, cooking, and spending quality time with her husband and son. Thank you, Sofia, for being with us today. Take it away.
Thank you, Rachel. Hello, everyone, and welcome to the APP's in Urology Symposium. And my name is Sofia Higareda, and thank you again for joining me for a fascinating talk on bladder cancer, to remove or not to remove the bladder. So objectives, we will talk about the epidemiology, etiology, and clinical presentation of bladder cancer. We will also review diagnostic and staging, and then describe the treatment of both non-invasive and muscle-invasive bladder cancer, discuss post-treatment surveillance, review bladder preservation techniques, and also just a special So bladder cancer, now what? So when a patient is diagnosed with bladder cancer, there is confusion, there's fear, there's anxiety, and it just quickly fills the room. The patient has a multitude of questions. What is bladder cancer? How did I get this? And am I curable? Do I need chemotherapy? Will I lose my bladder? Which is one of the major questions. And how long do I have to live? And the answer to these questions is not easy. And so we need more information. And so let's start with the basics. Epidemiology. Bladder cancer is the 9th most common common cancer in the world. It is about 3 times more common in men than in women, and is primarily seen in older adults. In the United States, white males have the highest risk, with roughly twice the incidence seen in African American and Hispanic men. although the overall incidence of bladder cancer is lower in women and in African Americans, these groups typically present with a more advanced stage when compared to white men. So the incidence of bladder cancer has decreased in some registries. Could this possibly be due because of a decreased impact of the causative agents? Are we basically doing our due diligence in telling people of smoking cessation? The mortality rate of bladder cancer has also decreased. And could this possibly be due to an increase in the standard of care? And this is according to the EAU guidelines on the non-muscle invasive update in 2013. Moving on to risk factors. Smoking. Smoking is responsible for approximately 1/2 of cases of urothelial cancers in both men and women. Smoking cessation does decrease the risk, but does not decrease the risk to the level of never smokers. There are other associations to consider, such as chemicals, so paints and dyes and solvents, other chemotherapy agents such as cyclophosphamide, and also schistosomiasis, so infectious disease agents, and then also considering possible congenital malformations as well. Occupations that increase the risk of bladder cancer. So considering painters that are working in a small closed-in environment, mechanics. Mechanics often clean their hands and underneath their nail beds with the same chemicals that they use to clean the tools, the grease off the tools after they're done working. So something to consider. Hairdressers and barbers also working with dyes when they're dyeing hair, if they're not wearing the appropriate personal protective equipment. So your social history is very important. Get your detective hat out. Try to identify the causative agent and give the patient education to reduce that risk. Sometimes this is easy. It could be smoking. Can you hear my dog? Give me 1 second.
Can't tell y'all how many times that's happened to me, whether it be a virtual patient visit or on a conference call where my dog decides to go a little crazy. Stay tuned. We have a comment from the audience that the dog is very passionate about bladder cancer. I would have to agree. It's good when your pets love what you do.
Okay, sorry for the interruption. So social history, so very important. Get your detective hat out. Try to identify the causative agent. Give your patients good patient education to reduce the risk factors. Sometimes this is easy. Smoking. Stop smoking, obviously. Sometimes though, that causative agent is hidden. It could be, for example, we had a 28-year-old female, 28, coming in, she's from Kuwait. We could not identify any risk factors. So we dug a little further. Come to find out, she grew up in a town that was close to the oil fields that were burning during the Gulf War. So very important to consider your social history when you're approaching a patient and trying to consider their risk factors. So clinical presentation. Most important, painless hematuria. There are other associated symptoms irritative voiding symptoms such as frequency, urgency, and dysuria. However, sometimes these symptoms, while benign, could be due to other diagnoses: UTI, cystitis, prostatitis, kidney stones. And so patients typically will be, this will lead to a delay in their diagnosis, and then further delay their treatment, which could lead to a worsened prognosis. Clinical presentation of metastatic disease could be pain, bony pain, constitutional symptoms such as fatigue and weight loss, anorexia, failure to thrive. And so these are important to look at presentation. So diagnosis. So the goal of the diagnostic evaluation is to determine the diagnosis, the site, and the extent of bladder cancer. We need a urinalysis, evaluate the blood in the urine. We need a full urologic workup, including looking into the bladder, looking at the urethra, the bladder in total, looking into the ureters and into the upper tracts, including the renal pelvis of the kidney. To help with that could also be radiologic imaging, such as CT, chest, abdomen, and pelvis. We're looking for any evidence that the cancer has gotten out and into other organs. And we're also looking, though, for any filling defects within the renal pelvis of the kidney. We can get tumors within the renal pelvis of the kidney causing filling defects, which we would see on CT scan. So important to do a full urologic workup. Cystoscopy and TURBT. This is our gold standard for diagnosis and staging. We need to visually inspect the bladder for any bladder abnormality. We're noting the lesion size, the number, the appearance, the location, and the growth pattern. Is it papillary? Is it flat and velvety? We're also doing an exam under anesthesia, which is where we palpate and feel if there's any masses within the bladder. This exam is done when the patient is under anesthesia, and it can assess the extent of the disease and whether it has the potential of getting outside of the bladder. So there was a randomized clinical trial in 2006 by Deverick and Zerlu that evaluated the importance of a repeat or a second TURBT. And according to the study, the tumor, the initial tumor is often understaged. And so it was demonstrated that a second TURBT could increase the recurrence-free survival rate. So your pathology report. Pathology report, we're looking at the location, obviously the grade of the tumor, whether it's low grade or high grade. We're looking at the depth of the tumor invasion. How deep did the tumor go into the bladder? What layer of the bladder does it involve? Is it flat? Is it carcinoma in situ? And did we get muscle in the specimen? Important to note within your pathology report. We're also looking for any lymphovascular invasion, and we're also seeing if we have any aberrant histology. One of the important parts of this slide that I wanted to mention is, as you can see here, as the tumors get larger, they invade into deeper parts of the bladder. One of the concerns with and limitations of the TURBT would be perforating the bladder. So obviously with the TURBT, we are limited on how deep we can actually go into the bladder, which is where the exam under anesthesia does come into play. These are some histologic variants. Obviously, urothelial carcinoma is the predominant histologic type in the United States and in Europe, and it accounts for 90% of all bladder cancers. There are the variants that are listed in red. So micropapillary, plasmacytoid, sarcomatoid, and small cell carcinoma. These are rare, but they are aggressive, and they have a very poor prognosis. I wanted to put in a separate slide for small cell carcinoma because the workup is a little bit different. It does mimic that of small cell of the lung. It is aggressive, and it does have a poor prognosis. One of the important things of small cell carcinoma is getting a brain imaging because of the affinity of small cell for the brain. We need to make sure that there are no metastatic lesions. Another important factor that we do here at MD Anderson is to give a patient, after they have undergone neoadjuvant chemotherapy, if their tumor is T3 and beyond, we are actually giving whole brain radiation prophylactically before we take them into the OR. So it is, their course is rigorous before we take them into the OR for cystectomy. So important to consider with small cell. So staging. So this is another diagram depicting the full bladder stage. So we have flat carcinoma in situ, which can be very flat and erythematous. Also, so TA, which is just involving the first layer of the bladder, which would be TA low grade or high grade. T1 is involving the lamina propria. T2 is involving the muscle layer. And then T3 is involving the perivesicular fat. And then T4 is beyond the perivesicular fat and into adjacent organs. And this is just a very good depiction of bladder cancer staging. Also, to look at lymph node involvement, we are looking at true lymph nodes in the true pelvis, looking at lymph nodes, and then also metastatic disease. The bladder likes the lung, the liver, and the bone as well. And so important, again, to look at your CT scan. So this is a staging system in a chart form. So we have stage 1 through 4. Stage 0 is our flat non-invasive tumors. And then 1 through 4 is T1, T2, T3. I will show T4 is any nodal involvement and then metastatic disease, any type of metastatic disease as well. And then moving on to non-muscle invasive disease. So non-muscle invasive disease can be flat or papillary. Flat can range from hyperplastic, so meaning that they are benign, there's just some atypia, or carcinoma in situ, meaning flat erythematous, and carcinoma in situ is cytologically malignant. Looking at papillary disease can range from urothelial papilloma, which is benign, to malignant low-grade and high-grade disease. So once the diagnosis is confirmed, patients should be stratified by their clinical factors to determine their risk of recurrence and or progression. So this chart is based upon the 2019 EAU guidelines. It divides the risk into low, intermediate, and high risk. Again, this is risk of recurrence and or progression. And we can look at the characteristics of each. So a low-risk patient is one that has TA low-grade, solitary primary tumors. They're less than 3 centimeters in size with no carcinoma in situ. Intermediate patients are patients who are TA, so non-invasive, or T1, so T1 high-grade. They're multifocal, or they have recurrent disease. And then looking at our high-risk patients. So these are high-risk, our carcinoma in situ patients, high-risk disease, either TA or T1, so into the lamina propria. And then also to note that TA low-grade, so these low-grade tumors, they tend to continuously recur. So we're looking at TA low-grade tumors that are multiple, that are recurrent, and that are large, that are greater than 3 centimeters in size. The EORTC risk table. So this is the European Organization for Research and Treatment of Cancer risk table. And what this does is you can basically put in your data of your patient, and it will give you the probability of recurrence and the probability of progression within 1, 2, 3, 4, or 5 years. Now, while this sounds and may look like it's a valuable tool, it does not include whether a patient has had treatment with intravesical therapies. Has a patient had any BCG? We're not able to note that here. And so that is where the accuracy of this tool has been questioned. There are other risk tables out there for use that does include whether they have BCG, but it does not include how much BCG they've had. So just to understand the limitation when we're using these tools. So the management of non-muscle invasive bladder cancer. So again, once we have the risk, we need to determine a plan. So this is just a different table. It puts it into a flow chart and into the low, intermediate, and high risk. And these boxes, it's all the same. We're looking now, we've added in the treatment. So our low risk patients, usually, again, they're solitary, one time, they've not had any other evidence of bladder cancer. So maybe they'll get a single post-operative dose of intravesical therapy following their TURBT, and then they undergo surveillance. Surveillance in the form of cystoscopy. And then we have intermediate risk patients. Our intermediate risk patients are patients, again, who don't meet the criteria for low or high risk, but we've outlined that in the previous slide. These patients may have plus or minus intravesical therapy postoperatively, but they do need some form of intravesical therapy in the form of BCG or another form of intravesical therapy, and we'll talk about that a little later in the slide. So our high-risk patients. Our high-risk patients are our patients who definitely need some sort of treatment, whether that is in the form of BCG therapy and with induction in 3 years of maintenance, or whether that is radical cystectomy. Important to note here that this slide also shows the importance of a secondary or restaging TURBT at about 4 to 6 weeks to determine and make sure that we're not missing anything with that initial TUR. So intravesical therapy, we use BCG. It's a live attenuated form of Mycobacterium bovis. Started about 1 to 2 weeks post-resection. We actually extend that out. We do 3 to 4 weeks, allowing for more for the bladder to resolve as far as recover a little bit more post-TURBT. It's given in a particular regimen. So we give it in an induction phase, once a week for 6 weeks. The patient comes back in 3 months. We look in the bladder, and then we give another round of maintenance BCG, which is once a week for 3 weeks. We continue this on. We start to extend out the maintenance for every 6 weeks, and we continue this for at least a year or 3 years. And in between here, we're also looking and making sure that the bladder is clear of tumor with office cystoscopies. I do have listed some alternative chemotherapy or intravesical therapy, such as mitomycin, doxorubicin, gemcitabine. BCG can be difficult to tolerate. It does have some side effects: urgency, dysuria, flu-like symptoms, fever. And if a patient is unable to tolerate, we can reduce down the dose to get them as much BCG as we can. And if a patient is still having symptoms, we then need to consider an alternative type of treatment. Also important to consider the BCG shortage that we have nationally. BCG is in short supply. So at MD Anderson, we are doing 1/3 the dose and giving our patients at least giving our patients BCG at 1/3 the dose and splitting that up, so that way we are allowing more patients to get treated. And it's, you know, there have been studies on the 1/3 the dose that is just as effective as the full dose, and patients may actually tolerate it a little bit better because it is a reduced dose at the very beginning. So, non-muscle invasive disease, very happy patients. These patients are very relieved to hear that they do not need to lose their bladder, so we have happy faces across the board. At least in this point in the game, they're happy, and that's usually their first question: do I need to lose my bladder? However, now moving on to muscle invasive disease. So the management of muscle invasive disease, we're looking at surgery, so cystectomy for patients. So our recurrent patients in T1 disease, so this is the disease that's into the lamina propria, and if this just keeps coming back while a patient is on BCG, we need to consider alternative therapy, which would be treatment as cystectomy. T2 disease, so T2 disease is disease that's into the muscle, and we have no other high-risk features. So nothing else in the CT scan, nothing else within the bladder. These patients go for upfront surgery. Chemotherapy, so neoadjuvant chemotherapy followed by surgery. So these patients have a more aggressive feature of bladder cancer. It has further invaded deeper into the bladder with T3, T4 lesions. We're also looking at these higher risk bladder neck and hydronephrosis at time of presentation. And I do have another slide where we're going to talk about the high-risk features that lead a patient to neoadjuvant chemotherapy before surgery. So we'll talk about that as well. And then in these subset of patients, so these subset of patients where we have more involved disease, so we're looking at nodal involvement or metastatic involvement. These patients, we may or may not aim for cure, because the cancer has already spread to distant organs. We may or may not be able to aim for cure. However, there are a subset of patients that if we're able to give them adequate chemotherapy and get them to a clinical remission, then we're able to move forward and get them into surgery. These patients have to have a lot of reserve. We are giving them tons and tons of chemotherapy. We are basically wiping them out and trying to get rid of, let's say, the 1 or 2 nodes that they have in their true pelvis to get them to that clinical remission. And then we, allow them just enough time to get better, and we take them into surgery. So that we do have a subset of patients that we do, this plus or minus surgery in the metastatic phase. So radical cystectomy. So radical cystectomy is the standard treatment for localized muscle invasive bladder cancer. It involves the removal of the bladder, adjacent organs, and regional lymph nodes. So we are doing a lymph node dissection here. For our men and our women, for the men, we are removing the prostate and the seminal vesicle. So we do have to talk about erectile dysfunction. In women, we are also removing the uterus, the cervix, the ovaries, and the anterior vagina. And in young women, there's been very few. So in our 28-year-old example, we did spare her uterus. We did this per the patient. and wanting to try to at least carry a child. And so we did spare her the removal of her uterus to possibly maybe allow her to have children at some point. But we do try to manage that on a case-by-case basis. We also are looking for our patients, we're looking at performance status, we're looking at their age, we're looking at pre-existing conditions, which are important in the treatment choices and complications post-surgery. If cystectomy alone is considered, so let's say, for example, in our T2 patients and in our patients who have recurrence despite intravesical therapy. So in these subset of patients, we need to get them to surgery in at least 3 months post their TUR. And so I do have a slide on our COVID, for COVID special considerations, but this is something that we needed to pay close attention to, especially during the pandemic, to try to get our patients in a timely manner. So urinary diversions, this is a big, big talk. So urinary diversions and helping a patient select through the different diversions that are available to them. So first we have the ileal conduit, which is a non-continent cutaneous diversion. It flows, urine flows from the kidneys down the ureters through a segment of the bowel, usually the ileum, and termed it the ileal conduit. A stoma is on the surface, and then urine is collected into an external appliance. We have, in this middle picture, is the Indiana pouch, which is a cutaneous continent reservoir. So it's constructed to avoid the need for any external appliance, and a patient self-catheterizes here to relieve the reservoir. The neobladder, which is the second most common, but it's an orthotopic neobladder, and it's formed from a segment of bowel and attached to the urethra. And it enables the patient to be able to facilitate some quality of life and self-image. They do have to self-cath, which may pose some issues. But all in all, these are the 3 urinary diversions. Most commonly, we're doing the conduit. It's least complex and least amount of postoperative complications. So the process of selecting a urinary diversion, it is very complex, and it involves a very detailed discussion with our patients and trying to decide which diversion is good for them. So this chart is from Up to Date, and it shows many different factors that are considered when selecting a urinary diversion. So risk of local recurrence, are we looking at patients who will eventually have some form of other cancer? Pelvic radiation, need for adjuvant therapy, secondary malignancies. We're also looking to see the patient's age. Have they had any previous abdominal surgeries that are going to make bladder removal just very difficult? Other medical coexisting conditions, diabetes, you know, needing prior heart attacks or strokes. Also the status of their GI tract. Are we looking at a Crohn's patient, which will make any type of urinary diversion very difficult? And also looking at some technical functions. So the tumor location. If a tumor is located near the bladder neck or near the urethra, we're obviously going to have to remove a portion of the urethra to get negative margins. And if we need to do that, that patient is not a candidate for a neobladder. Ability to catheterize. Is a patient going to be able to self-catheterize? These are all big, big questions to discuss with the patient. Sexual function. body image. Family support is another big one. That's something that we need to truly consider when we are discussing any type of urinary diversion with our patients. And this is where there's fear and sadness with bladder cancer. The discussion with the patient may take a lot of different discussions, sitting down with the patient to discuss their diagnosis and their treatment plan, to discuss urinary diversions, and give the patient credible resources, and doing their own research may help them come up with a decision. So this is a slide that selection criteria for our patients who do need to undergo neoadjuvant chemotherapy. So going over, this is something that is specific to MD Anderson. So a 3D mass on exam under anesthesia, prostatic stromal or vaginal wall involvement, lymphovascular invasion, hydronephrosis at the time of diagnosis, upper tract tumors, and micropapillary tumor or any type of small cell tumor. These patients are automatically sent for neoadjuvant chemotherapy. So chemotherapy before their surgery. And dose-dense MVAC has been standard for many, many decades. It's active, but it's a very toxic regimen. It's nephrotoxic, so it's important to make sure that we monitor a patient's kidney function, making sure that they can actually receive cisplatin-related chemotherapies. At MD Anderson, we do give it in this dose-dense fashion. It's, we find that it's less toxic. We give it every 14 days for 4 cycles, and it involves less mucositis and a few episodes of neutropenic fever. But again, most importantly, we need to make sure that a patient is a candidate for cisplatin because it is nephrotoxic. There are other regimens, gemcitabine and cisplatin, ifosfamide, doxorubicin, and gemcitabine. But important to note that it is inferior to carboplatin. Carboplatin and cisplatin, carboplatin is, the effects are not sustainable. So meaning that it does melt the cancer and it does work, but the effects are not sustainable. So we were seeing more recurrence with carboplatin versus cisplatin. Other chemotherapy regimens that are of interest: gemcitabine and andriamycin, gemcitabine and docetaxel. But other things that I didn't mention on this slide is immunotherapy. Immunotherapy has become very popular and has shown some very good results, especially with bladder cancer. So something that hasn't changed for decades, where we had a dose-dense MVAC and chemotherapy, we now can add in immunotherapy for some help. So post-treatment follow-up. So we've gotten the patient now through their chemotherapy if they've needed it. We've gotten them through surgery. And now what? So hoping that they don't need any adjuvant therapy, we do close follow-up with imaging and blood work. Imaging including CT of their abdomen and pelvis and some sort of chest imaging, whether that be chest X-ray or a CT of their chest. But we're monitoring these patients very closely for the first 1.5 years and having them come back every 3 months. We're looking for any evidence of recurrent disease, and we're also looking for any evidence for making sure that their diversion is working and functioning properly. We then move on to every 6-month follow-up and then yearly. We're hoping to get them to the 5-year mark post-surgery, and consider the patient cured at that point, and we transition them over to our survivorship clinic. And that makes for some happy patients. Typically at that point, patients have gotten used to their bag or their neobladder and hoping that they are continent. But typically at that point, patients have come to terms with their diagnosis and their plan, and they are happy at that point. However, now moving on to bladder preservation. So what do we do in an instance when patients refuse cystectomy? They do not want to move forward with bladder removal. What do we do when a patient's symptoms, they are metastatic, let's say, and they've had some good response with immunotherapy, but their symptoms need to be controlled. They have significant hematuria or significant pain, urgency and frequency, and it is interfering with their quality of life. And what if we have a patient who is not a surgical candidate? That is whenever we can consider bladder preservation techniques. However, there is a limitation, and the limitation is the risk of developing recurrent tumors throughout a patient's lifetime. So we would need to come up with a plan, a surveillance plan, meaning monitoring the patient's bladder and also CT scans, and making sure that the patient understands that there, could be risk that the cancer will develop in some other area of the body. Our bladder preservation strategies could include radical TURs, so where we continuously remove the tumors from a person's bladder. Again, these patients have to have no evidence of TUR, of cancer on a repeat TUR, and no evidence of CIS or prostatic urethral involvement. These patients, again, were needing to move forward with cystectomy. And so radiation. We found that radiation therapy does improve some of the patient's symptoms, radiation alone, or again in combination with chemotherapy. These again are in patients who we are sparing the bladder. So special considerations. So during COVID, we needed to make sure that we monitored our patients and we were balancing the risk from treatment delays versus harm from COVID. And it's a fear of cancer versus fear of COVID for our patients. So we needed to get them chemotherapy in a timely manner, and we could help try to see if we can set them up locally. And for our surgical patients, we were needing to make sure that, okay, what can we do to treat our patients with some sort of agent to try to keep the cancer at bay until we can get them into our ORs. As you know, ORs were shut down for a period of time, and we were needing to try to get a patient some immunotherapy or maybe even some small amount of chemotherapy to try to hopefully decrease the risk of their cancer recurring before we can get them into surgery. Most of the time we were trying our best to get them into surgery in a timely manner. We also needed to consider telehealth when possible. So could a patient particularly have imaging done here at the hospital, and then we call them with their results in a telehealth type of setting? That was helpful. It reduces the patient's risk and reduces our risk as well. And then we did find the bcan.org website to be helpful. It is also still helpful now. They have bladder cancer frequently asked questions in response to COVID. And that's something that we have sent our patients to so that way they can do their own research. And so during these surreal times, finding joy can be very difficult and very hard. But joy can be found in the smallest of things, like this little guy's smile and in his laughter. And that is what brings me joy any day and every day, coming home to this little guy. So yellow, so bladder cancer awareness. And that ends the discussion. And are there any questions?
Thank you so much, Sophia. That was excellent. A really wonderful overview of bladder cancer and treatment and surveillance. We do have a few questions already, and please, if there's anyone additional who would like to ask, go ahead and use that Q&A button at the bottom. So the first question is regarding the exam of a patient. So the question is, assuming that you palpate the bladder via the vagina for women and doing a pelvic exam, is that how you would do your exam in a male? Would you do a rectal exam for a male to do your exam under anesthesia?
Yes, so the exam under anesthesia is via the rectum. So you put fingers into the rectum and you push down into the pelvis. Also done for females as well. Yeah. And you're checking for mobility.
And so then when working a patient up for asymptomatic microscopic hematuria, do you always obtain a urine cytology, or only if the patient is older or has risk factors?
So it depends. So we bring the patient in, obviously, for ystoscopy, and then we evaluate the patient's past medical history. So if a patient, let's say, has had radiation, and it's likely that the blood was likely due to radiation cystitis, and we did CT scans to rule out any type of kidney stones, then we wouldn't do any type of urine cytology. Likelihood of it being from the radiation cystitis is high. But let's say we didn't find any high-risk features in a patient's medical history or in their background, and their bladder was completely clear, then yes, at that point we would do a urine cytology.
And what if your urine cytology shows that there are reactive cells, or my favorite, atypical cells? How do you, does that require further workup?
Yeah, it's different. We have a range. Again, we try to look at the patient's history. And so if they have a significant history of recurrence, we're taking the patient and doing another TURBT and doing random biopsies, from the dome, the lateral walls, and the trigone. But we're also looking into those upper tracts a little bit closer to make sure that we're not missing anything there. Sometimes, though, if a patient just has these recurrent, just atypical cells, we bring them back on closer intervals, monitoring the bladder for any type of recurrence. Otherwise, we're not taking them back all the time for TURs.
Next question, does your institution have a pre-cystectomy pathway for optimizing patients prior to surgery, examples being like nutrition or supplements?
Yeah, so we're working on it. It's been difficult to work on something like that. I think it's manpower really. We just don't have the amount of time available to do everything that we need to do to get a patient prepared, but it is in the works. We're hopefully trying to work with, we're going to work with patient education and hopefully maybe even do telehealth with our patients to try to help get them better prepared for cystectomy.
Awesome. Next question, the AUA recently updated their microscopic hematuria guidelines. So will MD Anderson modify their workup strategy?
Yes, we did get an email on the update, and we are going to start doing that as well.
Tell me a little bit about mitomycin and the use of that in a patient who is immediately post-op from their TURBT. I know that there's the question of, plus or minus an immediate post-op installation of intravesical chemotherapy. How often do you use it? What is your institution's thoughts on when or when not to use mitomycin?
So it varies from physician to physician. Not everyone buys into the mitomycin post-operatively. So my specific attending does not buy into mitomycin post-operatively. He's, every so often, if he has a larger tumor, then he may use it. but it's not something that he uses regularly. There are other physicians who use it on a regular basis and like it. But I don't know the data as far as why some do and some don't. I found with our patients, since our attending, or my specific attending, does not use mitomycin, they do fine with without the post-op mito and moving forward with BCG in about 3 to 4 weeks.
Awesome. Okay. Do you have someone who marks your patients prior to cystectomy, like a stoma nurse?
We do. We have a woundostomy department who does mark our patients. And they help us also with our neobladder patients and help them, teach them how to catheterize. And, you know, we put them on a kind of a flow chart and help them or teach them how to retrain their bladders.
That's great. This question might be a little bit broad, but perhaps you could touch on it for a moment. And I think this is the last one we'll take today just because we're running a bit out of time. But it's, how do you manage complications after cystectomy for patients with an ileal conduit?
How do we handle, meaning when they call in, or?
It's a little unclear to me. Perhaps to just comment on a couple of sort of immediate and then maybe a couple of long-term complications that you typically see with ileal conduit patients could be helpful.
Usually our ileal conduits usually do well. Most of the post-op complications with our ileal conduit usually are not related to anything surgical-wise. They're usually related to the appliance and not having the correct appliance. They're having leakage, and they become very frustrated with the leakage from their appliance. And so my response to the patient is that this is a trial and error type of period where once we find the correct appliance that works for them, it will be smooth sailing from there. But you know, working with the woundostomy nurse and working with the supply department will help them try to figure out which appliance is best for them. That's usually the most immediate post-op concerns when they go home. Now, neobladders, that's a different thing. You know, we're dealing with post-operative complication with fever, infection, patients not emptying their bladders all the way, leading to infection of the neobladder and then kidney infections. And those patients were having to, you know, either bring them in and having to readmit or, you know, manage them from an outside perspective.
Well, Sophia, this was fantastic. Thank you so much for such an excellent talk. We really appreciate it, all your expertise. If anyone has any additional questions, you can go ahead and email me via the link that you received for registration. Has my email address on it, and I can send those over to Sophia for additional answers. Thanks everyone for joining. Like I said, for future information about the upcoming 2 webinars in this series, follow me on Twitter at EuroPA_SD or follow UCSD Urology at UCSD_Urology. You can also follow us on YouTube, subscribe to our YouTube channel, which will be sent out in an email after this webinar, and also will be tweeted out with that link. And so you'll be able to watch this and all other recordings. If you like us, if you want to see us continue, please tell all your friends, tell all your colleagues. Make sure that you get everybody to register and sign on so that we can continue this program, which has been really wonderful to observe. So thanks everybody. Have a wonderful night. Thank you so much, Sophia. It's been great having you.
Thank you. Bye-bye.